Now, we have an extended Q&A with our moderator, Dr. Mark Moyad, who's done an incredible job moderating this conference. He does everything from help us pick speakers to topics and just fill in the gaps of what we need to educate people in. He works tirelessly on these conferences, and we so appreciate him. And he's the Jenkins Poe Kempner Director of Alternative Medicine Education at the University of Michigan Department of Urology. And he does really just an incredible job volunteering for PCRI and helping us with so many different factors. And another volunteer for PCRI is our executive director, Dr. Mark Scholz. And he has, founded this organization over 27 years ago. And because of him, we have this YouTube channel. And because of Dr. Moyad, we have all of our speakers together. They just do a great job of really bringing the oncology and the urology, sides of life together so that we can get both perspectives and really just provide a lot of education for men all around the world. We appreciate that they volunteered their time today, and they are doing an extended Q&A answering your questions. So without further ado, here's Dr. Mark Moyad and Dr. Mark Scholz.
Here we go. That's all I got to say.
Hey, Marco, so good to see you.
How you doing?
How are you doing up there in the great far northeast reaches of our beautiful country?
Well, I am in perhaps the most beautiful area in all the state of Michigan. I'm not going to reveal where I am, but people know I like to spend a lot of time up north. I call it God's country or whatever you want to call it. All I know is I've never been happier watering plants. I mean, what does that say about where I spend my time? I water these Norway spruces and I think that I'm in heaven. And I think, wait, this might be a lot more fun than writing a book actually, or doing a journal article, but at least I think this all comes around to you because you still haven't come to visit me. And so I will continue to apply the guilt toward you.
Well, it sounds like I just missed. Don't you guys have a cherry festival or something like that going on up there? That I'm sure they have the best cherry pie.
Well, yeah, they have great cherry festivals every year around July 4th. That's up in Traverse City. It's a little bit of a ways away, but it's the big event, sort of up north Michigan. And I don't want people to feel guilty eating cherry pie. Cherry pie is great, right? It's a nice reward. Did you know cherries actually have melatonin in them? So they can advertise that they've got a little bit of melatonin. You eat your cherry pie, you sleep 8 hours, your health better the next day.
Well, we should swing back and talk a little bit about melatonin, insomnia, and the patient clientele, the age group. Aging people is a major struggle for many people.
Yeah.
But I think we're going to start off and talk first about wonderful Dr. Rice, who you invited and whom you've had a relationship with for many, many years, on the topic of addiction, which is not the first thing that comes to mind when you're thinking of men's health, BPH. But what a compelling presentation. And the statistics, I think he said 1 in 7 people are basically a prisoner to this terrible situation. It was incredibly fascinating, and for me personally, I see the spin-offs in terms of all the things we struggled with. You talk about sugar addictions.
Yeah.
This is I used to smoke cigarettes, and that was I used to smoke cigarettes, and and I am more proud of having quit smoking than I am of having graduated from medical school. It was truly harder for me to quit smoking than it was to go through. I enjoyed medical school actually, but these sorts of struggles for us, I think we kind of all personally know that one thing that holds us a prisoner and that we'd like to get free of, whether it's too much sugar or maybe some of us struggle with anger issues or whatever. I think there's relevance to this whole addiction theme for all of us, and the applications for trying to get free, I think the principles are the same for all these different areas.
Well, I can just tell you that in all my years working with PCRI, which I think now is about 95 years, I think my whole life has been just dominated by this organization, but I have never felt so uncomfortable asking a friend to give a lecture, which is why I knew I had to invite him, because I don't need to go through everything in terms of who you know or who you don't, but we all know someone that has been devastated in families that have been devastated by addiction. And we all have friends, colleagues devastated by addiction. And I just thought, that was the elephant in the room in cancer that we don't talk about, because we're not, like I said to Dr. Rice, we're not talking about someone having marijuana at end of life. This is not what we're talking about. We're talking about self-medicating. And if there's anything I see from a public health standpoint that worries me more than anything, whether it's in prostate cancer or any other facet of life, and it goes all through all the generations, young and old, I see this penchant for addiction that's hard to get out of. And I just want to give the background story. I just thought I'd never heard a lecture on it at a cancer meeting, at a especially patient meeting, public meeting. It's time to do it. This is either going to be great or it's going to be not great. There's no in between, but at least we're going to now set a new standard for awareness. And that's what we did. And I didn't expect, like I told them, I didn't expect to be able to answer questions. What can I add? I'm this research doc, public health guy. Like, what am I going to add? But I can add the personal standpoint. So I know it's a long answer to your short comment, but it's so important for people to understand the background here, because I held up this sign with him and just showed him some of the common addictions, right? And it's not like we haven't in past PCRI meetings talked about some. So, for example, alcohol addiction. It's just incredible to me. Everywhere I walk in life, how so many people, including I think it could be colleagues, I think friends, somehow don't realize that they may have an alcohol addiction or are not going through it. And so we did this video at PCR, if you remember, we did it many years ago that got a lot of looks. I called it ABV plus V equals OMG when it comes to alcohol. There's a phenomenon going on in society where you take the alcohol content and you raise it, whether it's beer or other drinks, and then the volume goes up, and when you and I were younger, the idea of having a beer or two, wow, that was a big deal. And now these beers have double and triple the content, and so do some of these spirits, and the volume being served is higher and higher. And what happens, and he explained it too, is that when you concentrate the drug more and more, you don't dilute a drug, you concentrate it, the chance that it affects receptors in the brain and creates addiction goes up and up. So what I think we're seeing all throughout medicine, for example, and I wish we had more time with it, is an addiction, a penchant toward alcohol that people have a tough time escaping from.
I think what was really his professionalism and expertise it was so easy to see the organization and the presentation that he had, and the idea of it as a pervasive family problem rather than an individual problem. The person who's addicted feels very isolated, but in the context, it seems like the people that can move on and overcome this, change their lives, it's usually in the context of an environment of family or a team of people that care enough to reach out. And then the style of, or the approach that's needed to be successful. And he talked about practicing, the intervention group practicing, and it's almost like a performance to create that safe environment. It has to go according to plan, very carefully thought out, and it's a risky endeavor, but you can save a life with the life of someone that we all love deeply, someone in our family.
Yeah.
So it's so I am just so grateful for you introducing us to him and the techniques that he shared, and that doorway to hope for people that are, that you talked about, the enablers, people who have kind of resigned themselves to this reality. We're going to have to live with this alcoholic or whatever the addiction may be, and then compensate for them just so that we can get through the days and living this sad suboptimal existence because we don't have a pathway out. It was nice to see the steps that he outlined that can give people hope of a change. Not that it'll come easily or that it won't be a painful and difficult process, but at least a pathway out of that situation.
I like the fact that he mentioned, we talked about finances and paying for it, that a number of the programs are actually low cost. It's just a matter of getting to those resources because we really are sort of inundated today by the sort of California rehab, at least from the Midwest we are, where if you go type anything into Google that suggests an addiction, up comes a treatment center. Look, I'm not making judgment on it, but some of these are incredibly expensive. How they work, their track record of working, we can figure that out. But the reality is you get this impression that unless you have a ton of money, that you can't get help. And he's saying that's not true. Actually, it could be low cost if you do your research.
The other thing that came across, which is understandable that it has come to mind immediately, is one word. He said surrender. That that idea that we've finally reached the end. At one point he shared about how in the old days they thought you had to hit rock bottom. If you're an alcoholic, you had to be in the gutter, and then you could look up and see there's no more down. It's only up. I surrender. I give up. I'm going to try and rely on something outside. He didn't so much talk about, a divine outside reliance, but the people around him. And I think it's probably both. But that was very encouraging when he said that you can decide to surrender at any juncture as you're going down the elevator to the basement. You don't have to go all the way to the basement to make that decision that I don't have the capacity, to humble yourself and say, this is time for me to adopt a whole new paradigm for life, is really what it is, where you surrender that ability to say, I'll figure this out sooner or later. I've got this. And when in reality, he pointed out biochemically, for certain individuals, there is no way out without help, just because of the power of the chemistry of the situation.
The power of the chemistry just absolutely terrifies me, whether it's fentanyl, whether it's marijuana, great. Everybody wanted it legalized, but there's no great control. If you read any of the research, there's no great control over concentration. So he was talking about how when we were kids, it was a 1% THC concentration. And now we're dealing with 20, 30%. And that, again, you're concentrating the drug, nicotine, vaping, right? The idea is you might be getting rid of other things, but you're concentrating the nicotine. So now the drug itself becomes even more powerful to affect the brain. Look at caffeine. Look, I like caffeine, 1,3,7-trimethylxanthine. I love it. But the reality is the drinks now are concentrating it more and more. So the chances for addiction, the chances for dependence go up more and more. So the equation is there sitting in front. It's like, if you want to create addiction, concentrate more and more of the substance to get people addicted to. So this is where it comes up in lifestyle. I brought up ultra processed foods. And This is why I'm not trying to be PC here, but this is why when we talked about weight loss drugs, I said, you know what? I'm not a big fan of the price and all of that. I said it's an embarrassing price. The company should be embarrassed for what they're charging, in my opinion. But I'm a big fan of people now have hope to fight back the addiction that you have to accept that's going on with obesity. This idea of just cut calories and, just exercise more. We can get into that nonsense, or it's not your fault, or it is your fault. Can we put that aside for a second? Let's talk about all the compounds, all the ingredients that's being put into unhealthy food to make you completely dependent on more of that to get pleasure temporarily, which you actually experience withdrawal if you don't get those chips or donuts on a certain amount and concentration. So it affects.
How did you know? How did you know? You don't live in California. How did you know this about me?
Well, California is a mix. California's got some of the healthiest people who worry about every single thing they put in their mouth. And I think that's very stressful. Then they got people who are moderate. It's like everywhere else, but California is always ranked like Colorado, some of the healthier populations, but the
I'll confess, this is supposed to be good for the soul. So I studied biochemistry in college, and I understand how these, you get big sugar spikes after you eat concentrated desserts and things like this. So what you do want to do if you're going to eat cherry pie or something of that nature is have it after your stomach is full. That will blunt the evil to some degree. So that's my compromise for my sweet tooth, is I try not at least to eat them on an empty stomach.
The reason the weight loss drugs compel me is that people are being turned off to foods. If you talk to people on the weight loss drugs, they'll say, I can't look at a glass of alcohol anymore. I just am not excited. And I think that's exciting because I think they're testing it now, but the suggestion is in the laboratory that it's essentially affecting the areas of addiction and turning those off. So maybe it can help also people quit smoking. Maybe it can help them quit alcohol. And I love the fact that now we're leveling the playing field, because I don't think in our generation the playing field was level. I think it was all about concentrated food. It was all about unhealthy calories. It's still out there. And I just think when people say, oh, just fight it, again, that's why I gave Lee the story of when I was in college and we all got addicted to chewing tobacco. And I just thought, I'll just quit it, right? I'll just quit it when I get into med school or something, because I just need it to stay up late. And then I'm chucking it in the woods 50 yards. And 3 hours later, I'm getting withdrawal and I got to run and I'm looking in trash cans. I'm looking for this thing. I was like an animal. And I realized, this addiction thing and the withdrawal, that's why I wanted him to focus on withdrawal in the Q&A. Because people have to understand it's not that they don't want to quit. The withdrawal is so profound, and it just essentially takes you like a magnet right back, because as the hours go on, you experience these just gigantic highs and lows. The toughest people I've ever worked with, Mark, the toughest people, and I knew they were going to be the toughest, were the smokers trying to quit.
Well, that's what I say. I think
that was bite my head off. That was
the biggest accomplishment of my life, was quitting smoking. You should just be, I know we're not going to spend a lot of time on this, but I'm in the exact same place you are with these new, I call them miracle weight loss medications. And there's hesitation. These are relatively new on the, when is the backstory going to come out where people's ears fall off or something of that nature? And the reason I've gotten enthusiastic about it is because even if something is demonstrated, some problem shows up a couple of years from now, in the meantime, we'll have saved many lives through the fact that they do indeed cause weight loss.
Exactly.
So it's called a risk-benefit ratio. So, as every year goes by, and of course, these things are being used in millions of people, they can't even keep it on the shelf. It's so popular and so successful that the exposure to all these people, if there was going to be some shoe dropping later of, it causes brain cancer or something dreadful, probably should have seen it by now. So I'm 100% on board with what you're saying.
I mean, what I can just tell you about this is that we're learning more and more. There's no question the shoe that could drop, whatever that saying is. Shoe drops, 5 shoes drop. I just made up that saying, 5 shoes drop. But in the meantime, people have to realize we are 5 years into very strong data. And you're talking about, we've said this before, this is not a Mickey Mouse drug. This is a serious drug for a serious issue and should only be utilized that way. Meaning, these are people that have to lose weight, like bariatric surgery lose weight. These are people that have to lose weight now, or it's life-threatening now. So when people tell me, well, 5 or 7 years from now, your ears might fall off, yeah, that's possible. But the reality is, what was going to happen in those 2 or 3 years that they were taking it? If you're looking at the clinical trials, a lot of people were going to die. There were going to be mortality issues
because of the weight.
Because of the weight, and because of all the havoc the unhealthy weight has caused. But we continue to be surprised. Now, the surprise that happened in the past few weeks came from the European data. This is now being released. To make a long story short, the trial that got Wegovy, I still don't understand some of the commercials, but that's a whole other thing. I don't understand who writes these commercials. The trial that got semaglutide or Wegovy approved for reducing the risk of a cardiovascular event was called the SELECT trial. And so you're going to continue to hear more and more about the SELECT trial. It reduced these risks by 20% in just a matter of years. And so now they're getting an indication like this is heart healthy. So what happened was they've gone back and they've completely looked at it. And now before they've published in the European abstract, they said, think about this. This was so profound and it got caught up in politics. It got drowned out by other subjects in the past month. It says, in the cardiovascular outcomes trial of semaglutide or Wegovy in patients with overweight or obesity, but without diabetes, okay, a reduction in major cardiovascular events was achieved. Ready for this? Get ready to fall off your chair. And this is, I bet you, the first time an advocacy group has reported it. Was achieved regardless of the level of baseline adiposity. In other words, it didn't matter where you were on the obesity scale as much, and it didn't matter necessarily. Of course, the more weight you lost, the lower the risk. But for even the people who lost a little bit of weight that saw very little change, there was something cardioprotective about it. That was a shocking finding from the most
Well,
recent.
you know what it was that was cardioprotective is eating less.
Exactly. That's
I mean, it starts immediately. Today, I have a choice to eat less, and the benefit starts immediately.
Yes. To get ready for this, just to show you how coincidental this is, to get ready for this meeting, I was in the middle of a million other papers and meetings. We had a big thing from an international organization we had to get out on the prevention of prostate cancer. So I probably had the least amount of food I've had in the past 2 weeks. I got down to my college freshman weight, which is why my neck's skinny. I didn't think I had to lose the extra 7 pounds. Suddenly, I step on the scale and I'm 7 pounds lower. And I take my blood pressure and it's running low. Well, my family blood pressure runs high, so everybody's got to start taking medication. So I'm just taking my blood pressure and it's running low. I'm actually feeling almost a little dizzy. And so that's happening almost immediately. And that's with someone like me. So what you're saying is right, that physiologically what's happening when you cut down 50% of your calories right away, the body's responding by saying, let's get cardioprotective. I think that's a really good point on your end. Really,
it's exciting. Yeah, you're right. It's a gift from heaven because we all know how. I mean, I don't carry extra weight, but I do. I am challenged by eating the wrong foods, and so I can relate very carefully. If I see someone who's overweight, I can't look down on them. I understand these forces and these urges that are so difficult to wrestle with, and to have a medicine that all of a sudden can erase that urge. I mean, what a miracle.
Yeah, but people don't realize every time they say the shoe's going to drop, I'm not saying it's not going to, but here's what people have not been told. And I just pulled this up because I wanted to make sure I got the date right. Liraglutide, which one of the first of these in the category, which has a short half-life, was approved in the European Union in 2009. In the United States, it was approved in 2010. It's already been out almost 15 years. They haven't seen a safety signal yet there. So we have new, more powerful ones. But
you and I both know that we're not. Yeah, we both know that based on the mechanism of action that we understand, which is just reproducing normal hormones that talk to our brain synapses and tell us that we're not hungry. It's not a backdoor artificial way to make your stomach feel full. It's actually the very appetite center itself is being impacted by a molecule designed to impact it, and it's doing nothing else. So we really, just from what we know about the mechanism of action, we don't expect the shoe to drop.
I hope you're right, but I just don't, I just look at it like this. I look at it as if we're in the early stages of trying to study exercise, and people go, well, aren't you worried if you go running outside? We don't know the harms of exercise. And you go, yeah, that's true. And you become completely focused on the fact that you could step in a pothole or get hit by a car. That could happen. But let's look at the benefit overall of if that doesn't happen, essentially, the pros so far exceed the cons that, of course, I'm going to go exercise. You can always go find something negative. What I find so interesting is all these gurus out there that predicted in year 1 or 2 that all HE double toothpicks was just going to break loose. You're going to see high rates of this and that and thyroid issues here. And none of those have turned out to be true. Again, it's not that I'm a big fan of these companies, but I'm a big fan that we have a weapon to combat what people have been dealing with as an enemy for so long, and they had no weapon to fight it.
We've seen a lot of breakthroughs in the last 5-10 years, and because of the nature of modern research, where they're not, when I started off in oncology, all the medicines I used had been derived by trial and error. They boiled down some bark, they gave it to animals, and then they gave it to humans, and no one knew how it worked. Modern medicines, based on the understanding of the biochemistry of the human body, are like little software patches that they say, this is where the broken software is, and we'll just create a patch to fix it. And these miracle weight loss medicines are designed that way.
Yeah, let me bring up a couple new papers in my life, and I don't need to pull them. I've got them in my brain. And these all happened in the past few weeks. They looked at people on these drugs and the trials, and they thought, who gets the best results? Can we predict the best results? And one of the predictors of better results was if they added an exercise component to the drug. Because everybody knows you're already going to cut calories, right? So that component is very much taken care of. But the variable, the X variable that has lots of latitude is who's going to exercise and who's not going to exercise. So they have found, at least there's a signal that those people who exercise get a heart healthier benefit, okay, but also they're more successful at losing more weight. The paper that came just this week was looking at an older GLP-1 drug, and because what happens when you lose this kind of weight, not only do you lose muscle mass also, that's inevitable, 20 to 30% muscle mass unless you combat it with weightlifting, right? But you also can lose bone mineral density. So they broke it up into a bunch of groups, and they looked at who had the least amount of bone mineral density loss when they were on these medications. And the hint, again, was the people who exercised had less loss of the hip, less loss of the spine compared to the people that didn't move or didn't do exercise while on these medications. Which is why, if anyone pulls the paper that I wrote 2 years ago on the pros and cons of GLP-1 agonists, I published it, it's on PubMed. What I essentially said was, let's quit pretending that these drugs are somehow getting rid of lifestyle. What they really do is they hone in on the fact that lifestyle changes lives. And it's just as important to make lifestyle changes when you're on these medications as to when you're not on these medications. So we should be embracing that. And instead, people are making it look like it's lifestyle against the drug. No, it's not. There's a symbiosis there. And the sooner we accept that is the sooner we'll be more successful.
Yeah. We've, of course, in the prostate realm, we've been facing that in such a stark fashion because we give medicines that take away testosterone, which cause muscle loss, and we've seen the incredible turnarounds that people have if they can get on a weight training program, and they had to stay on careful diets because of the tendency to weight gain.
Yeah, and let me bring up one more thing at ASCO, and for those people that know ASCO, American Society of Clinical Oncology annual meeting is where a lot of papers that you'll see in the future are presented. They presented an interesting series in breast cancer patients because breast cancer patients have to go through a hormonal therapy, just like prostate cancer patients. So they lose hormones and the metabolism gets out of whack, and weight gain is a big problem in breast cancer, right? They looked at people on these drugs, on these medications in breast cancer, and they found that they didn't lose as much weight as the average person would, but they still lost weight. And it's just interesting that when these medications, which are so important, but they also slow metabolism to such a point that hopefully we'll see the day where it gets approved along with these medications to help you lose weight when you're already dealing with a cancer plus a cancer drug that makes you gain a huge amount of weight. So let me tell you, this is incredibly relevant to the PCRI, this topic, and it's only going to get more and more interesting as the months go on.
Yeah, one last comment on this, because probably the number one reason, pushback that I get from patients when I mention these medications is that they'll say, I acknowledge that I'll lose weight, but I'm going to have to be on it for the rest of my life. And my answer to that is, well, if you arrive at your ideal weight, it'll be a nice problem to have to consider whether you're going to have the option of stopping it or not. But a lot of the successful pharmaceutical interventions that have become so routine, lowering cholesterol, lowering blood pressure, lowering blood sugar, unfortunately do require ongoing treatment to maintain that successful new level that's been achieved through those pharmaceuticals. So the idea that you can, somehow the medicine is bad because you have to keep taking it to achieve those endpoints is not a very fair criticism. It's just so miraculous that you can make headway against an area that has been such a failure for many people.
Yeah, and along with your point, think about what we don't know, right? So if you look at the clinical trials of people stopping these medications, they gain about 66% back or about 3/4 back within a year. But you're talking about an average. There's a strong minority of people in the first year, and there's been some in 2 years, that when they stop them, for whatever reason, which we haven't figured out, they don't gain that back, or they might gain 25% back. Remember, that also happens in bariatric surgery. A lot of people gain weight back, but they just never get to the point where they were. So in the end, it's still healthy. And I think what you're going to find with people who criticize that I'll be on this for the rest of my life, we're going to find out in the next year or two that there's these, what we can call them unusual responders, or unusual people who go on cessation of the medication, where they won't gain as much as it's showing on the graph for whatever reason. Maybe it's because they've learned caloric control. Maybe it's because of their exercise routine. Maybe it's because of other behavioral changes overall, but it's coming. I'm telling you, I'm seeing this data and it's screaming at me that there's a minority of people, and we have to figure out who these people are and why they're successful, is that when they slow down the drug or they stop it, they don't see extreme weight gain right away.
Well, we've gotten used to that because of with all pharmaceuticals, we know that there's a component of trial and error, and and people don't seem to understand how different everyone's biology is, and that for some people, a little bit of medicine will go a long way, and then there are some people still that don't respond that well to these medicines. You're not going to know until you try it.
Hypertension. Largest meta-analysis just studied in terms of alcohol. Okay, hypertension. Let me read this to you. Overall, our results lend support for a causal association now between alcohol and the risk of hypertension, which is linear. In other words, we didn't even accept a couple of years ago that alcohol was a problem in terms of blood pressure. Now they're calling it linear. So you go 1, 2, you can see it go 5, 10, 15 points. The reason I'm bringing up this point is to emphasize and to complement your point, which is if you would have told someone on a blood pressure drug 5 or 10 years ago, wait, if you stop those 3 beers or 2 beers a day, you can drop 5 or 10 points and come off of your medication. People would have gone, what? I thought I have to be on this medication the rest of my life. So we've figured out lifestyle changes, and alcohol is one of the biggest that contributes to blood pressure increases. We've figured out in lifestyle what we can draw back on or remove that may cause a change in the cardiovascular number that may actually get you off the drug. So this idea that you'll be on medication for the rest of your life, look at type 2 diabetes and all the people who have been able to reverse it through lifestyle. I think that's going to play out with these weight loss drugs. So that's the point.
Well, how can it not? I mean, so if there's another factor that people don't realize is the successful loss of weight and the change of self-image that ensues, and a new sense of well-being, a new sense of self-respect, that, hey, I'm not the person I thought I was. And I'm actually a better person than I thought I was, I think takes people to a new plateau, which, as you're pointing out, in some cases, they'll sustain it without the drug because the drug has shown them the way to a new level of psychology that they can hold on to.
Or it will take them to a point of utilizing less drug, right? Yep. So they won't be dependent on such a higher dose. So remember, what the big change is going to be in the weight loss drugs is not just more of them, but different delivery systems. So Wegovy, that company, again, I have no relationship with these weight loss companies at all. Wegovy is going to come out with a pill in the next year or two. Their data is looking very good in phase 3 clinical trials. So they'll have the option of taking a pill at home, and then those people will have the easy option of stopping it when they need to stop it. So there's just so much more happening here. And I think we covered it within the realm of addiction, and it crosses over into addiction, but it's a fascinating time to have a weapon against obesity. I couldn't be happier for the public. I couldn't be happier for patients out there.
Yeah, me too. And I've seen the changes in our own clientele and the sense of peace and happiness that has happened in these patients who've had pretty much given up on ever being able to bring their weight situation under control.
Do you remember in the 1980s and 1990s? I mean, you're a lot older than I am. I mean, I think you're a good, 30, 40 years older than I am. So you probably remember this. Now, in reality, it's 70 versus almost 60. I'm sorry. It's just an easy joke to make because I'm the younger guy in the room. But do you remember? You have to share with the audience your 1990s, 1990s, because you've been practicing for so long. You've been seeing patients for long. Do you remember? And it still happens today. Every possible thing that could go wrong with statins was mentioned somewhere, someplace in the universe. You'd lose, your left big toe. This was going to happen. Oh my gosh, it was going to wreak havoc. Your memory is going to be, this is going to happen. Now think about it. We're 30 years or whatever since the approval of the first one. And virtually none of those came true. And all of this worry, right?
Well, there's still a big industry, and this is just part of the reality of the world we live in, is that anytime there's something that has the power to change things for the better, a counter industry always springs up that makes a living off of naysaying, always. Exactly. So there's always, and in the statin world, of course, there's a lot of grist for them to talk about. If what is it, 7, 8, 9% of people get muscle aches or something, and they have to go to a different, and thank God we have other options besides statins now. But so if there's 80 million people getting statins, that means there's 8 million people that had a negative reaction to statins. That's a big audience to cater to. And so patients, when they're researching, as they should, before my doctor wants to put me on a statin. So go online, read about it, and you'll come across websites and resources that talk about how dreadful statins are to this day. Yeah. And the same analysis as we've been talking about with these weight loss medicines, they're not a panacea. There's some people that they don't work in. There's other people that do have notable side effects. The good news is that a professional can mitigate those risks by starting with a small dose, monitoring closely, seeing how each individual reacts, and then making changes accordingly. So the risk of creating some irreversible disaster is practically zero. If they're handled irresponsibly, these are powerful medicines that change lives and prolong lives, but handled improperly, like any forceful cars, cars are a wonderful, powerful resource, but cause damage when they're used improperly.
Well, I was just going to say, I think it's really our job. It's my job in public health. It's really okay to mention limitations. It's really okay. And I know with you, I've belabored these points, but I want the audience to understand that we have no skin in the game. We have no skin in the game.
Yeah.
Again, I have to emphasize the price is embarrassing. I'm embarrassed for the company. I'm embarrassed. It's just an embarrassing cost. Now you can say whatever the reason is. I'm just saying it's an embarrassing price, and that's the issue. And so we have to also understand that the conflict of interest is a little bit embarrassing. I mean, there's a lot of people just giving out canned talks, and look, that's fine, but when you put all that aside and just look at the data for what it is and how it's changing lives, it's the preponderance of the evidence, like they say. It's the pros versus cons. They so far exceed the cons now that we just have to talk the way we're talking, because nobody was more skeptical of the weight loss category than I can remember I was at PCRI, because every other medication was almost an unmitigated disaster. So I never thought we would get to this point. But, that's what medical history is. You have doubt. The history's not that good. And then suddenly you wake up and something's invented. I don't care if it's immune therapy for cancer, right? If it's any of these sort of novel approaches, suddenly the world opens up. You turn a corner. You turn a corner. Anyway.
Absolutely.
I think we covered that well. So.
Yeah, I mean, if we had more expertise in the world of addiction, we could go on this further, but this is not.
This is our way of saying we don't.
Yeah. So we have to be humble about that. I'm glad you got a true expert to educate us. Beautiful, so let's talk about, there was one comment I wanted to make about Mr. Sharpe, and it became so relevant as you two were talking, and it came up that he'd had prostate cancer at one point. And of course, in the context of us knowing that African Americans have twice the risk. And then he revealed that he, not in addition to that, had a family history, which we know further increases your risk. And I loved his strategy as a thinking man to take appropriate precautions. And we talk about in African Americans, start checking your PSA at 40. Well, he started at 35. I mean, that was, is that a bad thing? I think that the only downside with investigating more deeply into the possibility of an early stage prostate cancer is if you approach it as a neophyte, sort of, well, whatever the system tells me to do. That's, of course, what the PCRI was designed to compensate for that and provide balanced knowledge so people can use that. But if you don't get to the starting line, if you don't do a PSA, and if you don't catch prostate cancer early, then that's where you hear the sad stories. In my professional opinion, I think probably 90% of the sad stories we hear are unfortunately due to people who didn't get diagnosed in a timely fashion at the get-go. There are a small subgroup of prostate cancers that are just super bad actors, but thankfully that's not the norm. It's usually because someone gets a late start, and Mr. Sharpe didn't make that mistake. And I wanted to quote one thing from him. He said, "I was not afraid to have a conversation with a doctor. And we don't normally think, why would we have a fear? But the idea that the medical system has its own agenda is pretty strongly founded in truth. So when people go in and talk to a professional who may have an agenda, maybe they want to do surgery or something like this, you do need to be forewarned and forearmed. But he had enough courage to realize that to counterbalance those dangers, which are real dangers, that having the knowledge of what was going on in his body would accrue more advantage to him than disadvantage. Yeah. I thought it was such a deep, profound statement, and I think he was trying to speak to not only African Americans but all men over age 40 or 50, that if they can just take the normal precautions, get a PSA once a year, that they can pretty much guarantee themselves they'll never die of prostate cancer. And if they don't do it, then you've had what we would call a preventable disaster, unfortunately, through the not getting a $30 test once a year.
I thought it was incredible he got tested at 35. Like, I think people should understand the pros and cons of every single test. But for him, if you look at the background, the family history of so much cancer so early, I could then argue, boy, I wonder if there's been other biomarker tests that he's had done, right? Because so many people so young. Yep. So, boy, he just took control of it there. And I thought that was incredibly, incredibly profound. But it stunned me because we went into it thinking he was just going to talk about men's health. Look, I know you can go online now and find that in these very little corners, he mentioned it. But like he said, he wasn't acting as a spokesperson until now. And so when he said it to me, all I kept thinking was, Mark, you're too old not to be candid. That's what I was thinking as he was saying, because I was so stunned during the interview. Because remember, this just goes. These interviews aren't, we're not stopping and starting. We're just going. And I said, do you know who else doesn't know? And I think he said, you. I don't remember what he said. I said, me. This whole interview, I thought we would just talk about football and we talk about lifestyle. And I said, I had no idea. And this is the very end. And I thought it was, what was also refreshing is, you have to admit, I mean, as long as we've been together, it's okay to have the spokesperson for prostate cancer be 78, retired, but that's also not the face. The face is a lot of families and a lot of men of vast different ages. And we just don't have enough men in their 40s and 50s, and men who also take care of themselves, I would argue, that have become spokespersons. So that's why I was sort of in awe at the end. Like, wow, you're 56. I kept saying he's 57. You're 56 and you're taking on this role of awareness. Good for you. Good for you.
People do think about what the repercussions are. If I'm diagnosed with prostate cancer, am I going to have a radical prostatectomy? Am I going to become impotent as a result? Do I really want to know? I think these are the kinds of questions that cause people to wonder if they want to have that conversation with a physician. And he's the kind of guy that thought this through and decided to have the courage to follow through and get checked, and found something at a very early stage that was like almost 8 or 9 years ago now.
Yeah, I think he said 8 years ago. No, we didn't talk about treatment. And I'll tell you why we didn't talk about treatment, because I didn't think that was my job. He did not go there. Mm-hmm. I thought he already did something so extraordinary that it caught me off guard. Look, it was so extraordinary, Mark, that I'm wearing his jersey again today. As you know, when we do Q&A, I never wear the jersey again the next day of the athlete that I interview. This is an exception, and it's an exception because he was exceptional. He was exceptional in the way that he just threw that at the end. He made sure, look, buddy, we're going to talk all this fun stuff, and I'm going to tell you that I can beat you in arm wrestling, but let me just end with the most poignant point, which is I went through this. So you think I'm so healthy and you think I take care of it, but just so you know, I'm also the face of prostate cancer. And I told my wife last night, I said, I'm still trying to get my head around this whole thing. So I'm just going to wear his jersey again the next day.
Well, let me make a comment, because he was so exemplary in his diet, in his fitness, and yes. And people who pursue this as diligently, almost religiously, the way he does, are often surprised that they come up with a health problem. And I think it's good for us to comment on what a health problem is. His health problem turned out to be a manageable and curable health problem. Yeah. People who who are not as diligent as him could have come down, as you were talking about, with it's not just the genetics, it's also what you do with the genetics in terms of your lifestyle, your exercise, your diet. And this has been shown in a number of studies that in all probability, if he hadn't been pursuing a healthy lifestyle, the situation, his type of prostate cancer actually could have been much worse.
Exactly.
So yeah, we're all in a declining slippery slope towards that inevitable day when we're going to go meet our maker. But the activities and choices, we can slow that slope, postpone those things with wise choices, but none of us are going to get out free. I mean, it's something due to age and just the own frailty of our human condition. We're going to face a problem someday, but we can postpone it and we can minimize it.
But the initial reaction of someone healthy who gets cancer often is, look at everything I did and I got it. And to me, the answer is very clear in the data. Look at everything you did and look what it could have been, but you got that.
Yep.
It could have been far more aggressive. And that's what the data is showing. And we're learning that now. You know, there's a paper by Zhang. It's called Healthy Dietary Patterns and Risk of Prostate Cancer in Men at High Genetic Risk. So it's one of the largest looks just published in 2024. And I had to review this for physicians, okay? And what I found so striking is here they're taking some of the best epidemiologic data, and they're realizing that people have some of the highest genetic risk, including even for fatal prostate cancer. So far, observationally, there's a suggestion that what they do makes a difference, that just because you are given genes doesn't mean you're going to have to wear those pair of genes the rest of your life. You can change your pair of genes. You can actually alter them. And so here was one of the most, when I was reviewing, I found one of the most compelling moments of the paper, which is what I was trying to tell Mr. Sharpe, but I didn't have the paper and we were running out of time. And I'm going to tell the audience what I meant by that. He said, yeah, I understand that. I've heard about that. I agree with you. And I'm saying, this is becoming profound. And what they concluded was when they looked at all these lifestyle factors in these men who were high genetic risk for getting aggressive prostate cancer, it said, however, compared with healthy weight, exercise, and not smoking, very little else made a difference. In other words, other things made a difference, but the major factors. And when I think of Mr. Sharpe, I don't think of someone who's smoking every day. I think of someone who's absolutely right at a healthy weight. And he's saying, I only work out about an hour a day, and he's 56. I'm going, no, So what the paper is saying is the big stuff matters. The other stuff makes a difference. But in these papers, they're saying if you take care of your stuff with the most important things, and they mentioned those three, staying at a healthy weight, being physically active, and not smoking was the most profound items they found among these men that helped them combat their genetics. It doesn't mean that diet doesn't make a difference. Diet impacts all that, but they're just saying that's what the group had in common, including the healthcare professionals that they saw lowered their risk. And that is just mind-blowing to me. And that's what I was talking about with Mr. Sharpe that I didn't get a chance to quote on at the very end.
Yeah. Well, it was a great interview that you had, and it was obviously, as you told him directly, an honor to have him. And he's an inspiration to right living and how it pays off. I was amazed at his diligence and his work ethic, and the his character just shines through the screen to very, very inspiring individual. Such a pleasure to have him.
And what I said at the beginning, I ran through too quickly. If you ever get a chance, look at his 2011 transcript or his actual speech when he was accepted into the NFL Hall of Fame. He gave one of the greatest speeches in human history of a pro athlete being accepted into a Hall of Fame. I don't want to ruin it for anybody. I actually read the whole transcript. This is a transcript of Shannon Sharpe's acceptance speech, or watch it online. I think it's 11 or 12 minutes. And it is so profound about family and giving back and honoring people who honored you. I don't want to ruin it, but every time I try to bring it up in the past 24 hours with friends, I get all gushy. Someone brought onions in the room. He talks about his grandmother who raised him, and all she really wanted was she wanted a house that wasn't wet inside when he became famous and rich. She didn't want to put out pots and pans and raincoats in the house because it was always dripping her whole life. They lived in abject poverty. He says he remembers eating animals from the woods that just died. I mean, you read this and you think this life he came from is just, I can't even believe he got out of this life. It was such an intense period. So I hope people read that. But I made him a fortune, and his team got very excited. And I told him that he needs to come out with a workout plan, and it's not called Ship Shape, it's called Sharp Shape. And he loved it. So Alex took a couple of pictures. The Sharp Shape Secret System, where he actually goes through his routine. I've watched that online with his weightlifting, because there's not many 56-year-olds that look like that and have a clear weightlifting routine and aerobic routine in their mind that other people don't want to learn about. And I was darn serious that he should do what's called the Sharp Shape System. And people want to be like Shannon Sharpe, but you got to show us what you do. And I'll tell you, I'm waiting for that phone to ring. They got really excited about the name Sharp Shape.
Well, he is an inspiration. And this is a theme, I don't think we failed to touch on this theme of fitness in pretty much every time we have a meeting. And like you say, this is one of the essentials. Why don't we go and spend the rest of our time talking about the BPH world? I think that the overview that Dr. Helfand provided was incredibly valuable. And this is an area that's, in terms of numbers, even substantially bigger than the prostate cancer world. And there's so many parallels. You brought up the idea of watchful waiting for BPH, which is something we call it active surveillance in the prostate cancer world.
But nobody talks about it in the BPH world.
Yeah. Yeah. And so I think the challenges from the PCRI's point of view are very similar to that of prostate cancer, is because we struggle with the fact that in many cases, the proceduralists are the ones who are deciding and explaining what the treatment should be. And inevitably, there's a conflict of interest. And that makes it very difficult for the consumer, the patient, to really understand, what's going to be best. And talks like this are incredibly helpful, as he went through and objectively explained all these different options to people. And the other thing that came out in your talk with him, of course, is that doctors who do these procedures, you really want to be talking to one who does this particular procedure, whether it's aquablation or something else, a lot, if not exclusively.
Exactly.
So that they have tremendous expertise, because they're going into the sensitive area of your body. You got one chance to get it right. The problem with that, of course, is that inevitably they'll be a little bit slanted towards thinking that that procedure might be best for you. And it's not disingenuous, it's sincere. It's just what they do. They're comfortable with it, and they think they can make it work for you. From the patient's point of view, that's difficult, because you're getting a slightly tilted field, and it's not intentional. I don't think it's intentional at all. It's just a reality of this space. And so I think it's good for you and I. Neither of us are urologists. We are not in the business of treating BPH in any way, but we're heavily exposed to it through our prostate cancer exposure. Men are already talking to us about their prostates. And by the way, Dr. Scholz, my prostate's big. What do I do? And so I think I would start probably talking about, to counterbalance the procedure-based idea, which was that wouldn't it be nice to solve this urinary problem really good once and for all? And I think that was probably the most compelling aspect of his presentation, that something like aquablation or a transurethral resection, which is one of the more thorough approaches and more durable approaches, and perhaps one of the more proven approaches, is attractive for that guy. And we run into these patients. I just want a solution. I want to move on with my life. I don't want to think about this anymore. Fix it for me today. And I think that the aquablation might be right up there at the top of the list. The disadvantages, of course, is that anytime you do a procedure, there is a potential for side effects, even in the best hands. And there is a component of general anesthesia, which in men in our age group entails a small but real risk. And if there was either a watchful waiting or perhaps a mild medication that you could kind of postpone and maybe wait for better technology to come along. The men that have waited for aquablation to come along, that hasn't been out for that long. So perhaps they were taking a medication or doing watchful waiting. So this sort of push-pull, this is a shared decision between the patient and the doctor. And this is the essence of the PCRI, is to educate the patients so that they can be on an even keel with their physician and have a real back and forth about this, the pros and cons of these decisions.
Yeah, that's my job. My job, it's just simply, we're here to tell you the pros and cons. In the end, you make a shared decision with the person that you trust in your medical team. That's what it's all about. But to go there with less hands on the deck is unfair, right? Because I always like to show this. I always like to show this because if I'm just Joe patient walking out there and all of a sudden they go, well, how many minimally invasive options do you have or just invasive? And I showed you sign only this many right now, but actually we've got more than this list. This is as many as I could fit with this font on the paper. Only this many, just go research them all. I would look at my doctor and go, are you kidding me? Yeah. I'm not doing that.
And does that include, really show the list again, Mark. Does that include pharmaceuticals, supplements, all that as well? Or is that just procedures?
No, this is just the invasive stuff.
That's just the procedures.
Oh, right. Yeah. No, this is not the full list.
Yeah. So now you have medicines, you have supplements, you have,
you have lifestyle, you have watchful waiting. But just think about this is overwhelming. And I don't know if you saw in the moment, I've known Brian. I love Brian. I sound so PC. I do. The people we bring on are people that I know they're already heavily vetted. I just know they'll be good. Imagine he's going to talk about aquablation. He spends the vast majority of his time talking about every other option under the sun and the pros and cons. That's a beautiful presentation. That's an objective presentation. I mean, and I made that clear behind the scenes. I said, we don't want this to be an ad. We want you to cover it. And when we were done filming, what people don't realize is I said, Brian, you covered it more comprehensively than anyone I've ever seen. And he goes, well, that's what you said I have to do. And that's what I do. And I was like, of course I would, you big dummy. That's how and it was just a beautiful moment that he covered all that. But the point you make is right. This is an overwhelming field. It's even overwhelming in the medications, Mark.
Yeah.
It is.
So let me just to try and simplify as a non-urologist, the way I'm thinking about these BPH. And he was very good about talking about that there are many different types of urinary problems. It's not just a big prostate. But if you look at the options that we have and the problems that men have, and it could be a big prostate, it could be an overactive bladder, that keeps people up at night. In bad cases, people block off altogether and they have to have a catheter placed. I mean, these things can get serious. And the way I tend to think of BPH, and just in simplistic terms, is first, if people have some symptoms that they can live with, I'm perfectly comfortable with watching them. If people have symptoms that they can't live with, I'm perfectly comfortable trying some medications. I'll just he mentioned like things like finasteride, Avodart. Turns out Cialis has activity.
Cialis has activity.
Flomax, Sildesin, Uroxetrol. These medicines can be tried in small doses, big doses, one at a time, in combination, sequentially, and you can fiddle around with these things if you have the patience for it. Sometimes that isn't enough, and then you're on to doing possibly some sort of a procedure. I tend to think in terms of small prostates and big prostates. And if I'm to the point where a patient says, we've got to do something, right now for small prostates, I like to do some of what he called more minimally invasive things before you start taking, hunks of your body out, which is, the TURPs and the aquablations and the more definitive. I mean, they'll even do surgeries to cut your whole prostate out if people are in a bad way. And so I tend to think of something like maybe Optilume for the men with small prostates and urinary problems, where they just put a device in your prostate and stretch it out and leave a catheter in to keep it from growing back for a couple of days. And we'll see if that fixes it. And the men that have ginormous prostates, I tend to think first, and he'd mentioned this, but kind of in passing, in terms of blocking the arterial supply with prostatic arterial embolization. Why am I attracted to that? Well, you go to an interventional radiologist, they put some stuff in the bloodstream in front of the prostate. You don't have to have a catheter afterwards. You don't have to be put under general anesthesia. Yeah. So those are the sort of the things. And then if someone's been through those things, an Optilume or has been through a prostatic arterial embolization, he pointed out that those may not have as durable effect as things like transurethral resections and aquablations. Then I would, at that juncture, be thinking of a more major procedure. And that sort of stepwise approach is, I think, a conservative one. I don't like putting people in the hospital for a procedure if I have other plausible alternatives. I've had patients die going into the hospital for routine procedures. I don't know if you've experienced that. I've had a big practice for a long time, and it's not one patient. I've had patients that have gone in for a routine kidney stone operation or a routine and died. And of course that's not the only bad thing that happens when they put you to sleep and give you general anesthesia and things. So I don't like to put patients at risk for something bad happening, albeit may be rare, when we have other less invasive options. So that's the way I tend to think of it, sort of a scalar approach. I'm excited about the aquablation because what he's saying with that presentation is that quite possibly we're not going to have to do any more simple prostatectomies anymore. That used to be the fallback position in men that had these really big prostates that were blocked, and you'd have to do an operation and cut into the abdomen and go in and surgically remove the gland. And you're talking about a 40-minute procedure instead of having to do a major prostatectomy for these men with big blocked prostates. I think that's a big breakthrough.
I couldn't have said any of that better myself. I mean, the reality is, and where does the future lie? I was so surprised he's talking about it now for treatment. It crosses over into prostate cancer. Maybe these people have minimal disease. And so these BPH treatments are going to open up some areas in prostate cancer, which are going to be mind-blowing. I'm sure of it. But I think, again, it's a pro-con game. There's a lot going on. It's highly confusing, and people need to take their time with it. But the funniest moment I had in the interview, I don't know if you noticed, or the audience noticed, is that I ended by saying, and I meant it, I understand when people get up there, they say, you need to do 15 or 20 and you're good at it. And I said, I'd rather have you, the guy who's done it 500 times than the guy who did it 15. And I know that people say, well, the 15ers and the 20ers and the 30ers, they're really good. And I still said, at the end, I don't know if it was caught in editing or what went down, but I said at the end, I'd still want the 500 person. I'd still rather have you do it. And I think that's the only message I add on to your wonderful message, which is at the end of the day, with all these procedures, I still want the man or woman, I still want the person that's most experienced. Yes. And I'm not saying experienced over life. They're still doing it on a frequency and intervals on a regular basis.
Yeah, after you've done your homework and you've decided what you think probably is going to be the best procedure, your work is half done. Right. Now you have to do the other half of your work is who is going to do it. Right. And to be willing to get on a plane and fly to a different city should be a small consideration in this issue. Whenever you go in for an operation, if you can find a talented center, an individual who's doing that one thing all the time, over and over and over again, is on at the forefront of their field and part of the discovery process and how to utilize this new treatment optimally. That's the doctor you want to be doing your procedure.
Well said. So at least what we're doing at PCRI is we had whole lip. That was with Dr. Dow. He did a good, and he'll admit. I thought it was interesting too that Healthfan said that one of the limitations of whole lip is you got to be really experienced. And I'm going, well, that's true. Yep. To me, you got to be experienced. And all of these, I couldn't agree more, but that's the word that keeps coming out over and over again. So
let's have you, I don't want to move on from this, before you talk to us a little bit about whether you think some of the supplements that are out there. So we're talking about this scalar approach, watchful waiting, maybe try some supplements. That doesn't work. Maybe try some pharmaceuticals. That doesn't work. Maybe try a minor procedure. Yeah. That doesn't work. Maybe go for something like aquablation, something more definitive as a scale. We haven't really talked too much about supplements in terms of like saw palmetto and there's a number of different things, some of which I think might not be working directly on, say, prostate size or shrinking prostate, but maybe because of their anti-inflammatory effects. I think there's a lot of confusion. We forget that not only do men get big prostates, they also get something called chronic prostatitis or inflammation in their glands as well, which can create symptoms that are unpleasant, just like a big prostate can.
That's why we talked about urodynamics and having a specialist really figure out what's going on, because it could just be overactive bladder. It could be a combination of overactive bladder and BPH. You know, these doctors that do it full time, these urologists, they're good for a reason. I mean, they do the testing required to help figure out the etiology or how best to go after this. So that's why we brought up. That's why, because you and I had talked about this privately. I brought up a sign that said, this is what's done in urodynamics. Ask your doctor about urodynamics, you know, and I think that was a very helpful point. I think the area of over the counter is interesting, but I think the area that's been missed the most in this category is not just prevention, but slowing the progression of it through lifestyle. And I know people probably watch all the time and goes, Moyad thinks lifestyle fixes everything. Well, I don't know if it fixes everything, but it complements almost everything, right? So I told Brian the story, and this is a true story. So for the American Urological Association, I got to write a definitive paper to educate doctors and future doctors on what to do lifestyle-wise when it comes to BPH and some other things. And I had to also talk about it in the realm of preventing prostate cancer. So I started listing all these things that had data to prevent prostate cancer and to prevent BPH. And then when I looked at the list after working 100 hours on it, I go, wait a second, this is the exact same list. It's the exact same thing. So whether we're concerned about alcohol or diabetes or dyslipidemia, high cholesterol, or inflammation, hypertension, this is actually from the actual obesity can contribute to aggressive prostate cancer, can contribute to an enlarged prostate, right? Tobacco, smoking, you know, whether some are on the fence or not, they all sort of have a hand in being prostate unhealthy when you're being heart unhealthy. And the reason I wanted to emphasize that is I remember in 1998, I was all excited. There was this article that I found because it was one of the first articles of healthcare professionals looking at what could prevent them from getting a BPH procedure, right? And so this is one of the largest epidemiologic looks. And this is 1998 when no one's talking about lifestyle and BPH, trust me. And so this is Platt et al. From Archives of Internal Medicine. And it was one of the things that really got me excited about lifestyle. So these are men who walked 2 to 3 hours per week had a 25% lower risk of BPH, okay? Physical activity was inversely related to total BPH, and that included surgery, which means the men that were most active and who were the heart healthiest had a lower probability of needing a more invasive procedure. And it's that kind of stuff that just continues to echo. So then this is more and more papers came out. And now we are here in 2024, and they're seeing it's a lower risk of nocturia, a lower risk of getting up at night if you're being physically active. So we have all these papers over the past, since 1998, and here we are in 2024, and it doesn't just whisper, it screams that lifestyle, wherever you are in the continuum for BPH, trying to prevent it, trying to prevent the progression of it, plays some kind of role that we can no longer ignore. Now, what I love to see in the Mark Moyad world, this is when I come back in the next life and I'm you or who knows, anyone. I come back in this next life and I want to do a study that will get funded, not have to worry about getting funding. I would love to see aggressive lifestyle changes up against medication, up against the supplement, because I don't know what would happen because it hasn't been done and it hasn't been done well, but I would love to see that. And then I would love to see those same supplements and I'd love to see those same medications where someone was also aggressive with their lifestyle. How much did it make the supplement work better? And how much, you know, did it make the medication work better? I think one of the biggest takeaways, and I think then we can go on to some general items, but I know you wanted to cover this. This is probably a 3-hour lecture in the Moyad world. I first want to emphasize safety. When you're dealing with an herbal, let's just say saw palmetto, let's just say it could be pygeum. When you're dealing with an herbal, the first thing I think to check, besides check with your medical team that you might be trying it, is check for one that is low cost, but has great quality control. So what I always taught the students, including the other day, I said, remember, I want you to all repeat this saying with me. Herbals are a different animal. And everyone go, herbals are a different animal. Herbals are a different animal. What's that mean? Herbals are about the stem, the root, the leaves, all these different sources coming into the bottle. You know, could it be high in mercury? It could. Could be high in cadmium? It could. It could be high in arsenic. We don't know. So that is where you have to make sure there's some kind of third-party verification system that says what is in this herbal is exactly this herbal, and it doesn't contain contaminants. It doesn't contain bacteria. There's no other kind of heavy metals we're concerned about. So the first step is actually not trying something. The first step is making sure that you're not doing harm to yourself and spending too much money for something. Well, what are third-party quality control groups that we'll talk about in the future with Alex and other people as we do the diet series that's going to be released soon? You know, there's a group called NSF. There's a group called UL. There's all these different labels that are called, there's one called in Canada called ISURA, ISURA. You're looking for a company that's allowed itself to be tested by a third party, unrelated to them, to walk in, test their ingredients and say, not only do you have what you advertise you're having, it's also safe. It's also a safe product to take. And that is one of my biggest concerns of all, believe it or not, when it comes to the BPH realm overall. The interesting thing, I'll leave you with this, and then if you don't mind, we'll cover some general stuff. The interesting thing about saw palmetto is it couldn't be steeped in more drama right now. Here's the drama. You have two major phase 3 clinical trials, essentially driven in the United States. I call them phase 3. One was called the STEP trial by Bent, B-E-N-T, and he was from UCSF. I think he's still there. And then there's the CAMUS trial, big government-funded trial, where you dose escalated on saw palmetto versus placebo. Both those trials found that saw palmetto was perfectly safe. That's the good news. They've also found that the placebo response rate is very high. I think they also suggested, but they found that they didn't work any better than placebo. So then you think, okay, is the story over? No, because in Europe, there's a prescription saw palmetto that for any negative study or neutral study that's happened in America, they have positive studies against pharmaceutical products, other prescriptions, including tamsulosin, which is Flomax. And you're going, well, what's the difference between these European prescriptions? Is it a quality control issue? Is it the way they prep the compound, which is different? They prep the active ingredients differently. It depends what camp you're on. You're going, is this the greatest placebo that's ever been invented? Or is it just that the Europeans, and there are some companies in the United States that make a more quality control product that gives it more of a pharmaceutical hit? That's why you have to work with your medical team. It's kind of like the invasive options. There's a lot to think about, but I just want to leave the audience before we go into it further in the future PCRI meetings that the first thing we should be thinking about is not the dosage, it's not the product, it's that you are moving into an area where quality control is paramount. It's absolutely paramount. And learning that what you are buying is cost effective and also essentially been tested. Like I'll get questions all the time, such as, let's just get out of BPH for a second. I go to Costco, let's say. I get this question, well, Costco has really cheap products over the counter. They can't be as good as the most expensive. And I'm going, all I can tell you is Costco has great quality control in general. They have a third-party group that actually tests for them. And so sometimes there's not a relationship between what you pay and what you get. Sometimes if you pay less, you do actually get more. So it's a matter of doing your homework. CVS has a program called Tested to be Trusted. It's revolutionary. It means that they're not going to sell anything in there, including their own products, unless it's been tested by third party. Why they don't advertise that more, I have never understood it. I have never understood why they don't advertise that more. So doing a little bit of this kind of homework is absolutely critical to at least starting something, working with your doctor that's safe to then gauge how you're doing overall. So that's a long answer to a short question, but I have never seen another category in urology and maybe in all of medicine where I think lifestyle makes a difference, except for cardiovascular disease, maybe, than in BPH. Even the BPH experts out there agree that lifestyle changes things. You know what they found interesting too when I was writing this paper is that as you gained weight, the medications for BPH in some cases became less effective because the physiologic change in the receptor happened. So in other words, when you talk about finasteride and dutasteride, they noticed that some people who gain weight or are obese don't respond as well. And then when they tested their tissue, they found that the actual mechanism of action or what it had to attach to in order to be effective had changed. So we're learning from pharmaceutical studies in BPH that the drugs are probably far more effective, or you have a better chance of them working if you are also working for yourself. So
yeah, and I think
that's my speech for the day.
Yeah, and just to close out this whole BPH section, the actual cause of BPH is, if you look at the official, textbooks, is unknown. But probably the leading theory is that it's a secondary effect of low-grade chronic inflammation. And low-grade chronic inflammation is the same thing that is what we call heart disease. Low-grade chronic inflammation of the blood vessel walls is what causes atherosclerosis, hardening of the arteries, leading to heart attacks, strokes, and whatnot.
Yeah.
And so the idea that chronic inflammation in the prostate occurs commonly in almost the majority of men is indisputable. I mean, you see the inflammation in the background when you do a prostate biopsy looking for prostate cancer. It's never been proven that the inflammation itself is directly the cause of the enlargement problem or the BPH problem, but it's, for now, as good an excuse as any that this chronic inflammation causes a reaction that causes the cells to replicate and the prostate gland to enlarge.
Yeah, and inflammation becomes systemic, right? And
yeah, so if you're, as you're pointing out, that lifestyle, if that is indeed the underlying etiology of benign prostatic hypertrophy, an inflammatory mechanism, how could diet and lifestyle not have an impact on mitigating that problem?
Absolutely. Absolutely. And it's funny, I find most of my inspiration in BPH of lifestyle from the pharmaceutical studies. You'd be shocked. When one of the most famous studies of Avodart, dutasteride, and to see if it could prevent prostate cancer, they decided to look at prostate volume and how that changed over time in this trial, in the placebo group and the drug group. What they found were people that were on cholesterol-lowering drugs, for example. I'm throwing out one of the findings that didn't get enough attention. It was brilliant. One of the cholesterol-lowering drugs actually slowed the growth of the prostate itself compared to people who weren't on them. Now, ultimately, is that going to make a dramatic difference? I can't tell you. And they would say, well, it's a little bit. It slows the growth a little bit, but it's statistically significant compared to placebo or compared to another group. But that's just one little hit going after inflammation, right? So what's the cumulative response? The cumulative response of slowing the prostate from growing. You know what the cumulative response is? And you're going to love this. And then I promise you, I'll get off my soapbox. How many men around the world have been diagnosed too early or have been diagnosed with prostate cancer that could never harm them because they had a rising PSA that had to be investigated that was the result of BPH?
Hundreds of thousands, millions.
Millions, yeah. Mark, meaning that when you control BPH, I think you also help control objectivity of your body.
Yes. And just one, because we talked briefly about cholesterol pills, so-called statins. And, I've had patients who had normal LDL levels. That means that their bad cholesterol wasn't really elevated, but who had bad atherosclerosis detected on CT coronary angiograms and CAT scans. And we proposed putting them on a statin or a cholesterol medication to lower their risk of heart attacks. And their logical issue is, well, my cholesterol's already low. Why are we taking a cholesterol-lowering medication if my cholesterol level's already low? And people often don't realize that there is also a built-in anti-inflammatory effect from the cholesterol pills. And it's inflammation that causes this damage to their arterial wall. So there's still an advantage for the statin medications, even if you have a normal cholesterol, at reducing the risk of coronary events. And as you're pointing out, you're seeing a spillover effect in the prostate, where it's probably also inducing a mild anti-inflammatory effect.
One of my favorite papers, you make me look way too good. You make me look way too. It's not just from wearing ties like you would wear, but one of my favorite papers this year that is just getting published, and this comes from a variety of different universities, including Fred Hutchinson Cancer Center in Seattle. So here they're looking at breast cancer patients being treated and their adherence to cholesterol-lowering med while they are going through the process. And this will be a paper that in my world will shout, but I don't even know if it will get any attention. So they followed people that were adherent, semi-adherent, or not adherent. And essentially, they found out that maintaining in breast cancer patients good adherence, they're going to find the same thing in prostate. You know this is going to happen. And adherence means at least 80% of the time you're taking your cholesterol-lowering medicine. after breast cancer treatment is overall beneficial for cardiovascular health and cholesterol. But essentially, the suggestion was there also that it reduced their risk of cardiovascular events, right? Or something that could also be increased from treatment itself. So what they're finding, whether it's in HIV, they're finding in breast cancer, I think they're going to find it in prostate, that when you take care of yourself under these enormously stressful conditions, which contribute to inflammation, the treatment can contribute to inflammation, that you're giving yourself a chance to reduce your risk of the #1 cause of morbidity and mortality in Americans, which is cardiovascular disease. So the question becomes, have we reached the point like in HIV and now they're talking in breast cancer? And I've talked to friends about this. If they're getting treatment for these different cancers, you need to talk to your oncology team about going on a cholesterol lowering med or doing things that are anti-inflammatory. And they'll go, but my cholesterol is fine. And I say, no, no, no. It's like what Scholz says. We're cutting down inflammation. We're not allowing it to take over. And I really think in 2024, we are at the point, I don't care if it's hormone therapy, I don't care where you are in the journey, if you're getting treated, these things can be hard on healthy. There has to be a discussion about what can I do to combat the inflammation that's about to be caused by the treatment that you're giving me, which can eradicate my cancer, but paradoxically, can increase my risk of a cardiovascular event. When Mark Scholz and I talk about statins, it really is a general word meaning heart healthy. So that means exercise. It means changing your diet for the better. It means cholesterol. It means blood pressure. The most ignored cardiovascular metric, which is done poorly in the United States, and we have to reteach how to do it. All of these things is the buzzword for statins. It's not just about the pill. It's about anything in lifestyle that reduces your cardiovascular risk. That's the buzzword, and I hope the audience knows that's what we mean. That's the buzzword.
And just as you pointed out, and you're already aware of all this data, but it's good to repeat it as you're showing the advantages for statins in breast cancer. The men who have prostate cancer undergoing radiation for cure for unexplained reasons have higher cure rates when they're on statins compared to when they're not on statins.
Yes.
And that phenomena has been reproduced in multiple different observational trials. And so in men that have gone through radiation and who are keeping their fingers crossed that they're cured and they're believing that it'll never come back, study after study shows that if they're taking a cholesterol pill, that they're more likely to remain cured than if they're not taking a cholesterol pill. And I don't have an explanation for that. It's just an observed phenomena in several trials.
I have an explanation for it since I've been publishing about it since 2003, but my explanation helps drive the point of what we're talking about. That's a buzzword. It's an association. It's not causation, meaning that it's associated. That when someone takes advantage of their health system, when someone takes a statin, this is like the multivitamin users we watch.
Yep.
People want to just bet their entire amount of money on the roulette wheel on one number. That's not how it works when it comes to lifestyle. The people who are willing to take that statin and adhere to that statin, gee, they're also the ones who don't seem to smoke. Gee, they're also the ones who are sensitive about their weight. Gee, they're also sensitive about their diet. Gee, they also, for example, eat more plant-based foods. What you see is it's an association with an overall lifestyle or a pattern that then ultimately they pay off. Now, what the statistics do and the statisticians, because I was a statistician, I mean, that's my background too, is statistics and epidemiology, is we always want to tease out the one factor that gave them the biggest hit. Like, what's the one thing that gets you to 100, And we always look for it, but you don't realize that in statistics, those are called confounding variables. There's always these variables associated with taking care of yourself that we'll never be able to pick up on, because the average person that takes care of themselves in 1, 2, 3, 4 ways, they look for way number 5, 6, 7, 8, 9, right? They continue. That's why when you see people who exercise more, tend to be less risk at taking up smoking. People who tend to exercise more tend to eat healthier overall. People who tend to exercise more have a relationship with their doctor. And so I think the relationship is not just statin-wise, it's what the statin user is doing in general to reduce their cardiovascular risk. This is what makes me wacky about diet too. People will go, well, what should I get in my diet? So people will go, Mediterranean diet. And I'm going, the Mediterranean diet is not a diet. It's a lifestyle. It is a lifestyle. It is a pattern of behavior. It is not about, if you really want to believe it's about something called olive oil, you will not get there. Olive oil is extremely high in calories. I like it. It's a processed product. I love it. But if you look at the average person who's getting that olive oil in the Mediterranean diet, they consume more fatty types of fish, for example, with omega-3 fatty acids. They're more likely to walk in the day. They're more likely to take a siesta. They're more likely to socialize, for example. They're more likely to eat fruits and vegetables. They're more likely to eat less processed foods. If you could just literally come up with a checklist of what the lifestyle pattern is in the Mediterranean, the people that do well, and they go through a Moyad checklist of 25 things that are healthy. And the idea that I'm going to tease out one of those and say, that's the reason they made it to 100 is naive thinking, and it will not get you to where you want to. What I've learned visiting all these places and seeing all these data, again, it's a lifestyle. Why did I live close to work? Why am I moving away to go live in, the woods and other places in the next few years? It's because what I also learned that at a point in time, you got to start reducing stress. And that's what also they do with this lifestyle. They find ways to reduce stress. But seeing their doctor is what they do. Eating healthy is what they do. Exercising is what they do. They are not big smokers. They're not big into alcohol drinking, even though it's associated with red wine. They're not big drinkers. It's a moderate game. So we come full circle here. And that's why I think, again, when we go back to the word statin or this pill, or some people want to talk about metformin, it's what are you doing around that to give you the advantage, right? What are you doing around that? So I hate to belabor that. And I know you've heard that speech from me probably 50 times in 20 years. But to me, it never, ever, ever, ever gets old.
People chip away at this. There's low-lying fruit in terms of, you can't change your whole lifestyle overnight. You try and identify the number one thing that can be worked on, and try and make some progress, try and have some success, and hopefully build momentum with future successes as you build through these changes. People are not going to have a religious experience and all of a sudden they're committed to taking good care of themselves. But there's as we go through and discuss these things, people can identify the thing where they can show the most improvement and get the most rapid feedback in terms of augmenting their future prognosis.
If you look at the compliance just in the United States with the 5 Bs, I brought up the 5 Bs when we used to have conferences. I'll bring it up again in the fall conference. I just tried to want to simplify life. And the reason I said 5 Bs, and 4 of them are objective, is essentially that if you look at the number of people in the US that have conquered just the 4 or 5, it's a very small group. It's a very tiny fraction of society. And you think, wow, I'm ready to write down the 5 Bs. What are those? So this is BMI or belly. It's your weight, right? How many people have conquered or been able to say they've been able to achieve a healthy weight most of their life? It is that alone will keep you busy the rest of your life, okay? But that's just number one, just being at a healthy weight overall, okay? And these are just measurements that you come up with. And then blood cholesterol. How many people have actually conquered their cholesterol? So now it's normal, it's in control. That's hard. How many people have conquered their blood pressure? That's extremely difficult. How many people have conquered their blood sugar? That's extremely difficult too, right? So just those 4 alone. And then let's just say about lifestyle. How many people can say that they have an optimum diet or they're doing well diet-wise? Or how many people can say that about exercise? How many people can say that they don't have a vice? They're not drinking too much alcohol, they're not smoking. Okay, that's number 3 overall. And how many people are saying they're getting adequate sleep? So, I wonder why the American Heart Association have come up with 8 lifestyle factors, which virtually nobody has conquered, but they found in their research that it conquers heart disease. We're going to find this throughout medicine. We're making this hard. We got to go back to the simple items because the simple items alone are hard enough. I'll just give you a standard. When I just think of you, and this is a compliment, I just give you a standard. How many people have you put on abiraterone? Okay. How many people have you put on that medication? I'm just picking that one out. How many people have you put on that medication that now have gone on to buy a blood pressure cuff from Omeron or another company that's accurate, and they take their blood pressure at home because one of the concerns, as you know, with abiraterone and a bunch of other drugs are the blood pressure changes. But blood pressures are already in the United States, the #1 killer of men and women in terms of cardiovascular disease, in terms of its contributing to the events. And now you've got a drug that's going to increase the chance of raising, it can help cure your cancer, but increase your chance of your blood pressure going up and becoming hypertensive. My point is that how many people on abiraterone right now take their blood pressure every week or two, are making sure they're monitoring it, are working with their GP to make sure it doesn't increase anymore, or actually the goal why they're on prostate cancer drugs is to lower their blood pressure. I'm asking you actually outright, how many people are you sure of have conquered that while they're on this medication? I just am wondering.
Well, I mean, it is routine. Abiraterone has a impact potential on liver function. It can cause damage to the liver. So monitoring after initiation is critical.
But not you monitoring. I'm talking about them monitoring at home. I know you monitor. I'm just saying. Who's done the study where they monitor?
Yeah, it has to do with patient education, that the rise in blood pressure with Zytiga or abiraterone is probably half the patients. So it is critical to monitor blood pressure as people initiate that. And there's abiraterone's not the only. There's other medicines that can cause blood pressure rises. So
exactly.
People. There is a proper way to monitor blood pressure, and that is to check it more frequently at home, because that's the real world, at different times, and then run those numbers, get 10 to 20 data points, the high number and the low number, and then average them. And that's how you find out what your real blood pressure is.
Yeah, and it's learning the basics. Blood pressure is, in all the Bs, in all the most important measurements, is the most often, and the American Medical Association will say this, it's the most often probably simplistic test that comes up inaccurately because it's not done accurately. So people have to learn how to properly take it at home. So you can go to the AMA, you can go to the American Heart Association, you have to go through a variety of steps on how to take it accurately. Now, I can walk you through all those steps in the future, and I will. And then you have to learn about the devices that actually have been validated, so they're accurate. So that's why I bring up the company Omron. You'll see them at CVS and Walgreens. They always pass the accuracy test, and they're fairly low cost. That's the one that I own when I take my blood pressure once a week. But when you got the majority of Americans now pre-hypertensive, or they're hypertensive, and then they're walking into all these treatments, as you describe, that can raise their blood pressure even further. And now just remember hormone therapy and the gaining weight and the blood pressure. So blood pressure takes on a paramount, massive meaning in the patient being treated for prostate cancer, which means they've now got to embrace the reading of it and the controlling of it, not just their doctor. And I guess that's some of the stuff that I wish would get passed on in the men's health meeting. And I think we do when we talk about it.
I think too that if you think about it, running a pressurized system 24 hours a day, 7 days a week for the rest of your life, there's going to be less wear and tear if you're running your blood pressure at a lower level. So there have been discussions about, what is an optimal blood pressure, and it keeps going lower and lower as people, as studies come in. And probably anything short of feeling dizzy every time you stand up, the blood pressure almost can't be too low if you're an otherwise healthy person and have normal kidney function. So I think you're right that we talk a lot about lowering cholesterol as a way to reduce vascular inflammation, heart attacks, and strokes. Blood pressure is equally important.
Yeah, I mean, think about everything we've learned in 2024 now that affects blood pressure. We talked about alcohol earlier. We talked about all the people that are already hypertensive, and now we have drugs that are increasing their risk of further hypertension. We talk about the enormous impact of just a little bit of weight gain on blood pressure. It's just profound. Some people are so sodium salt sensitive. It takes very little to increase their blood pressure overall. We talk about the effect of stress. There's a product out there that actually reduces your stress, and they're allowed to make blood pressure claims because we know the effect of stress temporarily on blood pressure. On and on and on it goes. And this was the primary goal of the men's health meeting, that the people watching, that we make sure that this stuff is not trivialized. This stuff is critically important for longevity and quality of life. And then you taking control of it. I firmly believe, Mark, that every man being treated for prostate cancer, for example, and every man who engages in any sort of systemic treatment has to know the ABCs of blood pressure, has to own their own blood pressure machine, has to understand the medications, has to talk with their primary care about making sure it's under control. They should do that anyway, but this should become mandatory for anybody that is put on any of these medications that could even be slightly risky. So anyhow, do you want me to leave you with the best study that I'm reviewing right now?
All right. Yeah, wrap it up with your best study.
So there's one that's just coming out now. So it's looking at people in their 80s in China, and they're trying to, and this is a very common theme. They're looking at, okay, when you hit 80, how could we predict that possibly that you would then make it to be a centenarian? You'd make it to be 100. So they're really trying to figure out this longevity secret. So this is in JAMA Network Open. This is this week or last week. And I'm reading it and I'm going, okay, this is a preliminary look. And I'm going, all right, what are they doing? What are the 80-year-olds doing to get to be 100? Okay, yeah, maybe they have a little bit of genetic advantage, genetic rocket boosters. And I'm going, here it comes. They're not smoking. They're hardly drinking. They're exercising regularly. This is literally their finding from following 80-year-olds. And this gets published in the Journal of the American Medical Association. They end up eating a diet that's diverse. So they're eating fruits and vegetables. They're getting fish. They're getting. The point is, overall, it's a majority healthy diet. They're not absolutely consumed like some people of everything that goes in their mouth. They learn that it's a pattern, that the overall majority of what they're doing is healthy. Oh, and by the way, their body mass index is in the normal range, or they're in a healthy weight. And these are literally the 5 that they came up with to help predict. They were the greatest predictors of longevity. And then they gave it to a statistician and said, well, which one of those 5 is the most important? And hallelujah, the statistician said, well, I'm not so sure which one, because all of them seem to be profound. So that just kind of drives the point today that don't let someone fool you that if you just get on a treadmill all day long, that's the only thing you have to do. It's about balance. It's about diversity. It's about moderation, but it's about all those little things that don't get a TV commercial, that should be getting a TV commercial. I don't know if you want to add to that, but I thought that was a great
No,
study.
Marcos, you've been our TV commercial today. Thank you. I appreciate it. This is stuff that has to be said. And this is what you and I observe in our clients that are manifesting extended longevity. One of the things that we have about 50 patients in the practice that are in their 90s. And the one memorable thing when you meet these people, and these are people that are driving into the office, and some of them have jobs and whatnot, is all you have to do is just shake their hand. And when you get the pressure back, you feel like you're holding the iron claw. These people are fundamentally strong. I think there's something that Moses told us in one of the Psalms. It says, we've been allotted 70 years, 80 if we're strong. So underlying strength, fitness is something that accrues to longevity.
Yeah.
And this is something that's universal. I'm sure there are people in nursing homes who are 90 who are frail and they're about to check out. But the people that are still viable and some of them, as I said, employed, the strength, you would not anticipate that someone in that age group would impress you. And these are not people who are trying to impress you. I just shake a lot of hands. It's part of my day-to-day life, and it catches my attention. They're not trying to impress me with their strength. It's just you can feel it. And so that very much matches what you've told us.
But what you're saying there is so profound. Let me just tell you, every year from what I've learned from the studies, and you're learning from the public, and you're learning from all of these meetings, is I've learned again that it's this pattern of behavior, and you keep wanting to add another little nugget, something else that's healthy every year. And I tried to learn it. What I began to learn as I'm approaching 60, because I'll be 60 pretty soon, is that I began to learn that the people who are really doing strength training, like you talk about, resistance activity, especially as they get older, it becomes a huge piece of the puzzle. Well, I wasn't thinking about that at 50, and I really wasn't thinking about that at 45. It's not that I didn't lift weights, but I kept getting inundated by studies that would suggest, here's a headline, skinny leg runners face higher rates of knee arthritis. In other words, the implication was, what we're forgetting is that 40% of our muscles, 40% of our muscle mass goes away by 70, 75, unless you do something. And that is just an unbelievable change. So, you know, I'm a runner, and people always tell me, well, you're going to need your knees replaced by 50. And they tell me all these things. What I noticed about the runners that were still running in their 70s and 80s is they had very big quads. They had very big hamstrings. They had very big supportive muscles to support their joints, and they were still working out. What I noticed is my muscles were getting thinner. So I started to get some hip pain. I thought, here we go, knee pain. The smartest move we made in the past year is we bought a Life Fitness machine. It's called a G4, and it allows you to do a variety of leg weights. And I do them every other day, like I watch people do my whole life who became stronger. This entire year, I'm probably running 5 to 7 days a week, almost 7 days a week, which I never did except when I was in high school. And the pain is not there. And what I'm trying to say is that this is what I've picked up now coming into 60. People say that strength training, but I'm talking about lower body, upper body, maintaining muscle mass, because once you hit that 60, 70, there's an acceleration of sarcopenia, an acceleration of age-related muscle loss. And one of the smarter things that we know we can do it is buy your own machine if you can. Some of these are low cost, and put it in your house and make it a part of your routine. And now we know it reduces your chance of total knee replacement. We know it might reduce your chance of a hip replacement. We know that your knee replacement and your hip replacement will last longer, building your muscles. So what you're saying about your patients is screaming in the data. And that was the latest change we made. I never thought in a million years, Mark, that I would buy a leg machine and an upper body machine and put it in my basement in front of a TV. I thought I'm always going to go work out once in a while. But this has become as important as my diet.
Yeah. Well, I should have shown a picture of my weight machine, which is right by my bed. And I try and get on that machine before I think of a reason not to do it, right when I get up out of bed in the morning. And it's a battle. We can get into talking about the psychology of how to fool yourself into exercising, perhaps in the future. Anyway, I just want to say thank you for inviting these amazing speakers who have been so helpful to us. Thank you for your very clever and apropos drawing them out, showing their strengths, and exposing us to this wonderful wisdom and knowledge, as you've done so many times. Maybe you should say a quick message about our first in-person meeting coming up this September, which you will be moderating for us in I believe, the second Saturday of September.
That's right. It's this has come from the staff. This has come from Alex. There was this idea. You remember that meeting a few years ago? We're in the midst of the pandemic, and these I call them young kids at PCRI. They are young. They're impressive. They want to have it in person. I'm thinking, but I think they made the right choice. I think Alex, Peter, the rest, they make the right choice. I think there was a certain magic about the in-person meeting that unless you've been there, if I even try to describe it, it's a tragedy. I don't even want to even try to be that eloquent. Yep. It's the camaraderie. It's the getting your personal questions answered. It's something I used to just crave in medicine, going to a meeting where people didn't hold back. They weren't worried. They weren't worried about someone looking over their shoulder. They spoke their mind, but they also spoke the data. They were very candid. It is the most refreshing health meeting, medical meeting I've ever been a part of, which is why I love being a part of it. And we invite the top people in the world, and the top people are going to be there. Elizabeth Heath, which is, I think, one of the greatest oncology speakers and knowledgeable people, apart from yourself, of course. I've just never seen anybody that good. She's just that good. Lori Klotz, who is the emperor of active surveillance. I mean, what needs to be said? Daniel Margolis, who you actually introduced me to, who's the emperor of imaging, right? He was at UCLA and now is over at Cornell. Then we have a guy named Dr. Brady. I always want to call him Tom Brady because of Michigan, but he's a reconstructive urologist, because look at all the side effects that people deal with. And he spent his entire career as doing reconstructive work and changing the quality of life overall. And then how about the radiation oncologist, Mac Roach? I mean, world famous. He just got a Lifetime Achievement Award from the large radiation group. I mean, Lifetime Achievement Award. Of course, he sent it to me, and I made fun of it, because we have that banter. But that is an all-star prostate cancer lineup like I have never seen. And then you and I will be a part of it.
And the in-person aspect of it is that the patients will be able to have direct questions and answers with these people after their presentations, which they make themselves available for extended periods, and which is always a very popular part of the in-person experience.
Yeah. So think about it. You're covering treatment, you're covering imaging overall, you're covering active surveillance. We're going to cover, as they know, my Q&A will cover a ton of lifestyle, and we'll talk about supplements, the good, the bad. And it's, again, I'm just going to say it. It's the most comprehensive educational day. And the next day we do Q&A live. Mm-hmm. It's the most comprehensive educational day I've ever been a part of, which is why it's so difficult as I kind of move towards slowing down. It's hard to say no. And I just want to also say, apart from this meeting, the staff currently at PCRI, so Alex's team and just the whole staff, they're not just young and vibrant. They know their stuff. They've really learned their stuff, and they're good. And I'm not just talking about knowledge. I'm talking about the media, the stuff that you see, the videos that you produce, the information that goes out there. It's as good as I've ever seen. And all of this comes together in one day at a meeting. It's really phenomenal. In fact, for people who don't know, for the past 15 years, after the meeting's over, we always go into a room and we sort of decompress. It's such an overwhelming amount of overstimulation and information that first thing we do is decompress. And it's one of my favorite moments in all the years, that when the meeting's done and we've worked for an entire year on it, we can just breathe and we know we did the right thing. So I think we're going to have a full house this year. I really do.
We'll be at a hotel near the Los Angeles airport, and I believe it's going to be 2 days, Saturday and Sunday. And we're certainly inviting you all to join us in person in September.
Buckle up. I don't think anyone's going to be disappointed. It's going to be really fun. Anyway, I don't want to get too effusive, but there it is. Thank you. It's always a pleasure.